tolerant phase with very high levels of HBV DNA, normal or near normal ALT levels, and no liver damage. So liver biopsy is normal. Then there is an immune reactive phase with ALT elevated, diverse titers of HBV DNA, and then there is an inactive carrier state that may be reactivated by immune depression or by the virus itself with E antigen negative and chronic hepatitis. So it's quite difficult to differentiate these different stages of the infection. It is complicated for non-specialist physicians, requires several blood tests in the majority of patients, and in middle and low income countries, access to HBV DNA testing is not available and affordable for everybody. So this is an important point. We should go to easy ways of diagnosis of hepatitis B. Otherwise, the access to treatment will be very difficult. You have heard the new markers of hepatitis B. They are very interesting from a scientifically point of view, but in reality, in clinical practice, we don't need these markers to diagnose and treat hepatitis B. So the initial evaluation and treatment decision is very important. So the questions are, which phase is this patient in? Does this patient have cirrhosis? I think this is the key question. Does this patient meet treatment indications? If yes, which treatment and what is the treatment plan? If no, how often should patient be monitored? Does this patient meet indications for HCC surveillance? If yes, which test and how often? So all these are initial easy questions, not easy to answer to every patient. So the diagnosis in the initial evaluation, we need to know the HBV replication. That means to have an HBe antigen, anti-HBe, and probably an HBV DNA. It is optional, the quantification of HBsAg and the genotype. Related to the liver disease, we need blood count with platelets, liver panel, creatinine, ultrasound, and liver elastography. I think everything is available for the majority of countries and majority of physicians. INR and liver biopsy are optionals and only in difficult patients. HCC screening, if indicated, we need ultrasound and alpha-fetoprotein. This is easy to get for everybody. CT or MRI are much difficult, much expensive, and not available in many places. Finally, we need to be sure there is not a co-infection with HIV, HCV, HAV, or HEV and Delta. I think it is very important to be sure there is not a co-infection, especially with Delta. And be sure about the common comorbidities, and to be sure alcohol consumption, lipid alterations, all are important to exclude. Regarding the non-invasive test, elastography has become the usual system to ensure, to be sure the patient has or not liver cirrhosis. But there is a point. There are many patients in the gray zone, so we don't know whether those patients progress or not to liver cirrhosis. And this is very interesting study in California and Taiwan. This is a retrospective cohort, more than 3,600 patients untreated and without liver cirrhosis at entry. And you can observe 38% of those patients were in the gray zone and persist in the gray zone over time. So there are a subgroup of patients who cannot define whether or not they will progress to liver cirrhosis. And this is important because probably some of these patients need a liver biopsy to know whether they need or not treatment. So at the end, the most important is if the patient has liver cirrhosis. And when we diagnose chronic HBV infection, we need ALT and AST levels, E and NTE, HBV DNA, a non-invasive test for fibrosis, and or liver biopsy for those difficult patients. If the patient has liver cirrhosis, we need to have an HBV DNA, which is undetectable. We think about other diseases. If it is detectable, the patient needs treatment, and this is important. So this is the simplified diagnostic algorithm in upper and lower middle income countries. HBsAg, serum aminotransferases, HBV DNA, and assessment of fibrosis. The APRI looks inadequate, but the FIB4 is being used in many countries. It's easy to get, it's cheap, and when it is over 1.5, we can assume that the patient has chronic liver disease and probably is progressing to liver cirrhosis. What about the current therapies? I have stressed that in the previous conference. So they have many pros, are oral drugs. They have an excellent capacity of suppression of viral replication with a good safety profile, and they are indicated in patients, even decompensated cirrhotic patients. Some cons, there is a long-term therapy, even lifelong, so there is a matter, there is a problem. There is a very low HBsAg clearance rate. No more than 1%, 2% of patients may clear HBsAg. The risk of hepatocellular carcinoma persists, and this is important. All these patients with liver cirrhosis should be monitored, and surveillance for HCC is imperative among those patients. And these treatments are not indicated in the immunotolerant phase, as Maria has commented, and inactive carriers. So which are the challenges in NUC-suppressed chronic hepatitis B patients, patients under NUCs? So adverse events, you know that most of them, tenofovir and entecavir, may produce bone alterations and renal insufficiency. And there is a financial burden. Until now, they are generics and the price are affordable for the majority of people. But we need to increase HBsAg loss and viral suppression. This is very important. And up to now, we cannot get this functional cure. The efficacy and safety of the recommended NUCs are very clear. So the antiviral efficacy for tenofovir, tafol, and entecavir are very, very high, while the HBsAg loss is rare with all of these drugs. There is no drug resistance except in patients with entecavir previously treated with lamivudine. In those patients, entecavir should not be given because 50% of them present with resistance. The dose adjusted to renal function is important, including tenofovir and entecavir, but not TAF. This is one of the advantages of TAF in that situation. And the same is true for bone alterations. The cost is low for tenofovir and entecavir and high for TAF. So you know that the WHO has marked the endpoints, the objectives for 2030 towards the elimination of hepatitis B and C. And that means to decrease the new infections by 30% reduction and 10% reduction in number of deaths. For 2030, we hope to get a 90% reduction of the new infections and 65% reduction in the mortality from these viruses. I think they are very optimistic endpoints. I'm not sure whether it will be possible or not, but this is the route to get the objectives, and we all should try to go ahead. Again, I think it is very important, the prevention of the infections. How to do that? So first, vaccinate 90% at least of the newborns. This is easy to do, this is very important. Again, to test and detect and screen 100% of the blood donations and 90% safe injections. These are key points, easy to get, but very important. On the other hand, screening 90% of people aware of the infection. Again, I tell you, there are a lot of patients unaware of they are infected. And this is very important. And therapy for 80% of the diagnosed patients. If we want to eliminate the viral hepatitis for 2030, we need to do all these points, otherwise it will be impossible. Here you can observe the impact of HPV vaccination in newborns in Asia, and you can observe the decrease in the implementation of the HPV vaccination from 1992 to 2014, and you can observe the decrease of the HBsAg prevalence among these people. And same is true for HCC in Taiwan. These are all studies in Taiwan trying to vaccinate everybody, and there is a decrease in the vaccinated population of the incidence of HCC among people from 6 to 26 years old. So the strategies of vaccination in different countries in 2021 are different in different regions. But in the majority of countries, in the majority of areas, the programs of vaccination are very active. And in that sense, this is cheap and easy to do. And there are different foundations, as the Bill and Melinda Gates Foundation, who are spending money supporting these activities. And this is very important to get a 90–95% of coverage of vaccination among newborns. So, again, I think we have comment on that. There is a real cascade of care, and we should avoid this point. You can observe the number of infected people, the number of diagnosed, so there is a gap of 82% between infected and diagnosed patients. And finally, on treatment, there is a very little proportion of patients. So this cascade is terrible in certain regions. Of course, in Africa and regions of the Americas, in Eastern Mediterranean region, in Southeast Asia and Western Pacific region. So there are regions where this cascade is terrible. We should avoid, we should try to diagnose 90% of the infected population. So the advances in diagnostics are very important to do that. So first we have saliva test with results within minutes, with no expertise or laboratory required, and can be self-administered, and antibody results, you can have them in minutes. This is very easy to do. You don't need an expertise, you don't need a physician or a nurse, so any voluntary can do that. Then the dried blood spot, again, requires minimal expertise, is suitable for mass screening, results take 2–3 days, and can give viral load, so which is very important. You can have the result in 2 days and link to treatment the patient. And finally, the point of care is the HBV DNA testing. Again, is minimal expertise required. HBV DNA result in 1 hour. There is a limited capacity, and it is ideal for instant linkage to care. In many countries, there are some vans going with the machine. They do it immediately, and they have the result in 1 hour and give treatment immediately to the patient. So I think these advances in diagnostics can improve, can diminish the gap between infected and diagnosed patients. And then we have the macro-elimination strategies. That means go to the people on risk. Who are those people? People who inject drugs, sex workers, men who have sex with men, or HCV-infected patients. Again, patients with liver cirrhosis, HIV-infected, patients with HCC, and patients suffering hemodialysis. In many countries, it is very important to check the migrants from endemic countries. This is very important up to now with the world moving all around. This is a key point. So to check those migrants when they arrive to a country with low incidence and low prevalence of HBV infection. And of course, non-vaccinated against HBV. There are people who were older at the time of vaccination, and we should take care of this and check for HBsAg. So patient awareness is a major issue. So patients need to know that they are infected. This is a study in US, and you can observe from 1.3 million of infected people, only 34% were aware of the infection, and ever treated 28%. So again, in a very well-developed country, there is a gap between infected and treated patients. And finally, and I will finish with that, people with hepatitis B need a voice at the table. So infected people have to be in the meetings, need to be informed and have a voice. Because people with hepatitis B must be partners in the process. What works on paper does not necessarily work in the community. And the global community and needs are diverse. And this is not the same in Pakistan or in Spain or in US or in any other country. So patients have to be part of the discussion and part of the solution. And hepatitis B management needs to consider patient and community needs, and needs to address quality of life, physical, emotional, social impact, fear, shame, worry, anxiety. These infections produce a stigma, and this is very important to discuss. And those volunteers and those infected people who know that can help the physicians to help family, to help the patient and the community, and avoid discrimination and isolation of these patients. I think education and care is absolutely primordial and important if we want to eliminate viral hepatitis. With that, I want to thank you for your attention and thank you for the invitation to this important meeting. Thank you.
So thank you so much, Professor Dr. Rafeal Esteban, for our wonderful sessions. So any questions from the audience?